Good afternoon, everybody, and welcome to this grand rounds on Theranostics for neuroendocrine tumors. It gives me great pleasure to introduce my friend and colleague, Dr. Ghassan El-Haddad. We actually trained together at Penn, and as Piyush was pointing out, there are three former fellows from Penn in this auditorium today. Piyush is actually our senior at Penn, and Ghassan and me were colleagues. And Ghassan wanted to study more, so he stayed there for a year more after me, and then he joined us here at Biomed, the PET Center, worked for 2 years. And then he went on to do radiology in up northeast. I think he liked the cold weather too much, so he went to Connecticut. And then he went back to Penn to do interventional radiology, so he's, I think, just not getting enough of education. He's triple board certified. He's certified in nuclear medicine, radiology, and interventional radiology. And he currently practices in Tampa at the Moffitt Cancer Center. His dream is to do something called interventional nuclear medicine, but I think he ends up doing mostly interventional radiology and a little bit of nukes here and there, and that's about it. He was involved in the NET-1 trial that was evaluating the impact of lutetium-based PRRT for neuroendocrine tumors. And so with that background and his experience, I think he is a very good and apt speaker to share his thoughts on Theranostics for neuroendocrine tumors. He's going to cover Ga68-DOTATATE for imaging and lutetium-177-DOTATATE for therapy. And this event is sponsored by an unrestricted grant from AAA that was bought by Novartis that makes these compounds, as a disclaimer. So without further ado, Dr. El-Haddad.
Thank you. Thank you, Amor, for the introduction. It gives me great pleasure to come back to Shreveport after 10 years. Like you mentioned, I was here for 2 years, and it's very nice to see back friends here in town. So I'm going to cover the Theranostics for neuroendocrine tumors. These are my disclosures. Talk about, in general, about neuroendocrine tumors, mainly gastroenteropancreatic neuroendocrine tumors, go over the diagnostics, focusing on OctreoScan NetSpot, therapeutics, PRRT, background, European experience, NET-1 trial, and then that to the approval of lutetium-177-DOTATATE, and then some practicalities about how to implement PRRT and potential future directions. So as an introduction about neuroendocrine tumors, these neuroendocrine cells are widely distributed throughout the body. So neuroendocrine tumors can actually occur in almost any organ or tissue. But the most frequent localizations are the GI tract and followed by bronchopulmonary. Most commonly, they're in the small intestine and the pancreas. So if you take GI tract, this is most commonly where we find these tumors. They're mostly non-functioning, which means that they don't secrete any hormones, and these patients, they may spend many, many years having the disease without even knowing because there's no manifestations. It's a very slow growing usually. Which leads to another problem where 60 to 70% of patients are having metastatic disease at diagnosis because it's very slow growing, usually and indolent. So by the time it gets diagnosed, it's already metastatic. And that's a problem because these patients have limited amount of treatments. Because of the indolence of the disease, it's making this disease much more prevalent than other types of GI cancer. The incidence has been increasing in the last decades, about more than 600%. And since it's slow growing, patients live for many years, the prevalence has increased significantly. So we have a much higher number of patients who have who are living with gastroenteropancreatic neuroendocrine tumors. And for the purpose of the talk, I'm going to be focusing mostly on this part of the tumors. We're not going to talk more about the outside of the gastroenteropancreatic area. And these are very heterogeneous tumors. And the way we look at them, there are so many ways, and it's different for every single patient. So they can have low or high tumor burden, widely metastatic disease, or liver dominant. They can either be, most of them, stable or slowly progressing, or it could be severe, very fast progressing. They are classified by their location: foregut, midgut, hindgut, and pancreas, low grade, intermediate grade, or high grade. And that's very important to know how to treat these patients. So every single patient who gets diagnosed will have to go through an assessment and to make sure what type of disease or where do they fall in this algorithm to try to determine how we're going to treat them. Hormonal status, whether these tumors are functional or non-functional, it's also important to try to control these symptoms if they have any, which is mostly diarrhea, abdominal pain, flushing. These are most common symptoms when the disease is functional. And very important for the treatment of these patients is whether they have high expression or low or absent expression of somatostatin receptors. This is very important for their prognosis and also for the way we're going to treat them. So how do we diagnose these patients? Diagnostic workup is pretty much, most of the time, these patients are diagnosed by a triple phase CT scan or ultrasound. They come in for non-specific symptoms, abdominal pain, diarrhea, or any non-specific symptoms. And they get a scan, and we found the tumors. And that's when the workup starts. You have much more investigation being done, biopsies to know what exactly the differentiation of the tumor, etc., staging the patient. Most of these patients will get anatomical imaging, CT, MRI, ultrasound. They'll get an endoscopy. An endoscopy with endoscopic ultrasound, ultrasound-guided endoscopy is very important when we're trying to determine whether the patient is going to be a surgical candidate or not, especially around the pancreas, see the size of the tumor, what structures are involved, vessels, etc. And once we establish that, this is pretty much just based on the size of the lesions. Then comes molecular imaging, which gives you a better idea about the functionality of the tumors and, most importantly, about the amount of somatostatin receptor expression, because that can help triage this patient and determine how we're going to treat them. And as far as molecular imaging, we have the two agents, kind of the first generation OctreoScan or indium-111 pentatriotide SPECT-CT, which has been used for so many decades, and we still use it. And the newer agent, which is the Ga68-DOTATATE PET CT scan. And I'm going to go over some of the differences between these two, and FDG PET CT scan. And FDG PET, even though it is not kind of indicated when you have somebody diagnosed with neuroendocrine tumor, it has a significant amount of prognostic information that can also tailor the therapies. And the most important aspect of these neuroendocrine tumors is their somatostatin receptors. That is really the basis for the molecular imaging and also the therapy. So most of the patients who have gastroenteropancreatic neuroendocrine tumors have high expression of somatostatin receptors, mainly the somatostatin receptors number 2. And the treatment for these patients can be with sandostatin, because these hormones, they go to these receptors and can control the disease. And from there, we moved on to make imaging agents that will go to the same receptor. And the common denominator here is these 4 amino acids. So this is the part where we have similarity to the human somatostatin that goes to these receptors. And this is in common with the treatment, which is the sandostatin. That's what we treat these patients for control of the disease. And also for imaging. So you can see the indium-111 OctreoScan has the same 4 amino acids, at least this part that will go and attach to the receptor, the somatostatin receptors. Or whether for treatment, we have the Y90 DOTATOX, same 4 for amino acids, but now we have differences in the chelators. Instead of DTPA, we have DOTA, and we have different radionuclide. This is for imaging. This is for treatment. This is another imaging agent, gallium-68-DOTATATE. And I mentioned the gallium-68-DOTATATE. So you switch this radionuclide, put it here, and then you'll have, sorry, not here, put it here. Then you'll have the gallium-68-DOTATATE. So basically, we're working on the same peptide that will go and attach to the same receptors, and we're just changing whether we add peptides to it to increase the affinity to the receptors, and we're changing the radionuclide to make either a radioactive material that gives us imaging or a treatment. And for example, these are comparisons between the OctreoScan and gallium-68-DOTATATE. You can see the significant difference between these two agents. These are just planar images. Of course, you can get SPECT as well, done 24 hours after the injection. You can see a little bit of heterogeneity in the liver and some lymphadenopathy. But with the gallium-68-DOTATATE, there's a significantly better images. And these two scans tell us the same thing, whether this patient has high expression of the somatostatin receptors with significantly better image quality on the right side. But for the most part, the distribution of the agents, as far as normal variation of the uptake, is pretty much similar, even though here you don't see it. But for the gallium-68-DOTATATE, we have normal activity in the pituitary glands, salivary glands, thyroid. You may have a little bit of uptake, the spleen, kidneys, adrenal glands, and pancreas. These are normal areas of uptake of the tracer. And somebody who's reading these scans will have to adjust to how this tracer is usually taken up. This is another patient with gallium-68-DOTATATE showing multiple foci of uptake in the liver. You can see normal activity in the adrenal glands. The kidneys, obviously, they excrete the agent, so you'll have a lot of activity in the kidneys and also the urinary bladder and the spleen. These are lymphadenopathies. But you can see the amount of difference between the gallium-68-DOTATATE PET CT scan and the SPECT PET scan. There's significant improvement in the image quality. And I made this table just as a quick comparison between these two agents. So with the OctreoScan, which is the one on the left side, you'll have to have multiple acquisitions. Normally, we do at 4 hours and 24 hours later. Sometimes you have to give the patient laxatives to clear the bowel because there's a lot of bowel activity. The OctreoScan has a lower somatostatin receptor 2 affinity, so you can have a better affinity with the net spot or gallium-68-DOTATATE. This can be imaged only 40 to 60 minutes after the injection. So it's much easier for the patient. You inject the patient, get the scan, and they go away. If the patient is coming from an outside, another city or another state, you don't have to stay overnight to get their scan. The PET has a much better spatial resolution and higher accuracy when they were compared together, 94% versus 82% better accuracy for the net spot. Now, OctreoScan is much more available because the gallium-68-DOTATATE is generator produced. It's relatively simple labeling on everyday basis, but we don't have yet generators that are spread everywhere. So we're still limited by how many net spot scans we can do, at least for the time being. And we have no really insurance issues with the OctreoScan. With the net spot, we're still, because it's a newer agent, some of the insurance companies sometimes ask really crazy questions. Why do you want to do the pelvis? Just do the abdomen. Or they will reject these for some random reasons. So you still have to do some peer-to-peer to be able to get this approved. But for the most part, at least in our institution, it hasn't been an issue. And most of the cases when they are ordered, the scans are being done. The other issue is that because OctreoScan has been there for many decades, all the studies that were done, the phase 1, 2, and 3, were done for patients who received the OctreoScan, being evaluated with OctreoScan before getting the therapy. We don't have that yet for the net spot. It's kind of extrapolation that whatever we see on the OctreoScan, if we see it on the DOTATATE, we should have the same results. But it hasn't really been tested. So since this is has higher accuracy, we don't know yet whether we're going to be over-treating patients because now we can see things much better, or maybe it will have a much better outcome because we can see lesions that are much smaller at an earlier stage. This is another example of an OctreoScan. So I just showed you planar images. It doesn't mean that OctreoScan is really still not appropriate. You can get SPECT CT images, which can show you relatively very good distribution of the tumors. But this is, in comparison, a Ga68-DOTATATE scan. And you can see on the left side, this is a tumor in the liver, a patient who had a small bowel neuroendocrine tumor. I did microwave ablation, and on follow-up, you start seeing an increased uptake along the resection margin. And this is good to show to your surgeon that you can't really save and fix everything because this patient had his right lobe removed, and now he has recurrence at the surgical resection. I know they don't like to see these scans, but now with the net spot, we're much better in showing that to them. So there is this focus here, and it's very hard to see it on the CT scan or even the MRI because of the metal. It's causing artifact, and that's a huge impact on the patient because we know the patient has complete response here, but he still has disease elsewhere. And just to show you, when the patient recurred in another location in the liver, just 5 millimeter, and actually probably smaller, we can still see it on the net spot. So extremely accurate and helpful in determining these and seeing these small lesions. Another patient, very tiny lesion. And for some reason, why is this? Yes. All right, so now you can see that it was very hard to see on the non-contrast CT scan when we did the ablation, but just a tiny few millimeter, 3-4 millimeter lesion, this you can never see on the SPECT CT. It's below the resolution. So you can see the importance of this new imaging agent. Which brings us to the main thing about this session is Theranostics. And I told you in the beginning how most of what we do is focus on these patients who have the somatostatin receptors. And the idea about Theranostics, this is not new or unique to neuroendocrine tumors, but just in summary, so we use a diagnostic tool if it goes to a certain receptor, let's say, for example, iodine. And Theranostics is not really new. We have been using it in nuclear medicine for decades, but right now it got a more attractive name, where you have, for example, I-123 goes to the thyroid. If it goes to the cancer, you can give I-131. You know exactly where it's going to go. With neuroendocrine tumors, we use the same thing, but focusing on the somatostatin receptors. So you have a diagnostic tool, which could be the OctreoScan, could be the net spot. And since we know where this radioactive agent is going, now we can give the treatment. And the combination of both is called Theranostics. Now, of course, it starts with the diagnostic and then therapeutic, but I guess diagnostic did not really sound well, so they just went with Theranostics. And this is very important because this is personalized medicine, clearly. You see the lesions, you give the drug, it's going to go to those places. There's no question. That's the beauty. So the rationale about PRRT, which is the therapy arm of the Theranostics, since most of these patients who have gastroenteropancreatic neuroendocrine tumors have high expression of the somatostatin receptors too, now we can send the same molecules, but now we can change, instead of, for example, indium-111 or gallium-68, we can put Y90, lutetium, and those radiopharmaceuticals are going to attach to the receptor, incorporated into the cell, where they're going to be closer to the nucleus, and by emitting radiation are going to cause DNA breaks. Now you can see this is an example of indium-111 because this happened to be the first agent actually for PRRT where they gave high dose of indium-111 octreotide to try to treat these tumors. However, indium-111 has a low activity, so this was done in the 1990s. It travels only 10 microns, so it's one cell. And it had its benefit in controlling mostly symptoms, but not much overall response. Then came after that the Y90 octreotide, and more recently the lutetium dotatate. And this is just a small table to show you about the results of indium-111 octreotide when it was used for treatment. Data from Europe, small series, but mostly symptomatic relief was the most of benefit of these patients. But the objective tumor response was relatively rare. So it was beneficial, but it wasn't really revolutionary because you had to give very high doses to get the same results that we're getting right now. So the newer agents are the lutetium and the Y90-based PRRT. The difference between the agent is Y90 has a much higher energy, so it can travel further than the lutetium, which has its benefits and downsides sometimes. If you're looking at the effect of radiation on normal tissue around you, because we see that, for example, when we do radioembolization for the liver using Y90 microspheres, it's a little bit different, but you can control the tumors, but with radiation with Y90, you can have much more than you actually wanted, and you can end up having long-term side effect in the normal tissue. And these were tested in phase 1 and phase 2 studies, mostly in Europe. Lutetium, because it's lower, and due to its affinity to the receptors, because with the Y90, it was mostly used with the DOTATOC, this agent has lower toxicity to the kidneys, because this is where most of the drug is excreted. And the cycles that were done in phase 1 and 2 trials were mostly 2 to 5 cycles, every 6 to weeks interval. The benefit of lutetium or Y90 is that you don't really need a radioactive agent to exactly to the same, to all the receptors. You can have what we call a crossfire. So you have the radiopharmaceuticals going and attaching to several receptors, and because the radiation is going to fire all over the place, you can have a cloud of radiation. It's much less with lutetium than Y90 because it's a lower range, but that's one of the benefits of having a crossfire and cloud of radiation instead of just one focused radiation inside the tumor. This is a crowded table, but I'm just going to focus on the largest series from Rotterdam with the Erasmus study that was on 310 patients. This was with the lutetium dotatate. And the overall response rate of 29% was pretty significant compared to other therapies that were available. And as far as progression-free survival and overall survival, also the same study, we had 33 months progression-free survival, median progression-free survival, and overall survival was 46 months. Most of these patients had liver metastases, and it was based on this trial that the phase 1 trial was started, which is the NETTER-1, and it included maybe 41 sites all over the world, 14 in the US, which we were part of, and it was published in the New England Journal of Medicine last year, in January 2017. So these are the two studies, basically, the Rotterdam study, the Erasmus, and the NETTER-1 that led to the approval, the recent approval of lutetium-177 dotatate this last January. And to talk about the NETTER-1 trial, this was a trial for patients with mid-gut neuroendocrine tumors who have somatostatin receptors and they were progressive on long-acting octreotide, 30 milligrams, and that was one of the arms, compared to high-dose octreotide, LAR, 60 milligram. And we had, these are the two arms. Patients received either LAR, 60 milligram, every 4 weeks, or they received 4 administrations of lutetium-177 dotatate, plus the SSA, which is the 30 milligram, just for symptom control. Every 4 weeks, every 8 weeks, they got 1 injection for a total of 4 weeks. And the follow-up was supposed to be for 5 years to look for overall survival, etc. And the main endpoint was, the primary endpoint was the progression-free survival. The secondary endpoint were response rate, the overall survival, safety, intolerability, and importantly, the health rate, quality of life. Patients were more than 18 years of age, metastatic, locally advanced, inoperable, well-differentiated mid-gut neuroendocrine tumors. So it was a very specific group of neuroendocrine tumors, mid-gut neuroendocrine tumors. From this, of course, now the approval is much more generalized, but for the purpose of the study, it was a very small kind of group of patients. But these are most of the patients that's with the well-differentiated mid-gut neuroendocrine tumors. These patients were evaluated by RECIST criteria to see if there was progression by imaging or not. They all had to have somatostatin receptor positive disease. If you don't have SRS positive disease, these patients cannot be treated because the drug is not going to go where it's supposed to go, and they had to have good performance status. The population characteristic between the two arms were very similar. Like you can see here, most of patients had involvement, or the primary site of disease was in the ileum, and metastatic disease was mostly in the liver, lymph nodes, and bone. And now having treated patients in the expanded access, and also when we started seeing patients clinically to be treated, I would say 90% of the patients are going to have liver, lymph node, and bones. Also, other similar characteristics in these patients, they all have very similar Ki-67 percentages. So they were G1, G2, well-differentiated tumors. The Krennig scale, how much uptake the tumors had on the OctreoScan, they were also pretty similar. Chromogranin A, very similar, and 5-HIAA. And the results were very significant. Patients had, you can see here on the long rank curve, where you have significant improvement in progression-free survival, 79% reduction in the risk of progression or death. The PFS wasn't really reached, but it's estimated to be maybe 40 months, but I don't think it was reached yet. So you can see there was very clear split of the curves between the two arms, and that's what the basis of how this drug got approved, basically. The improvement and the benefits was also across the different patients' characteristics. So whether they had alkaline phosphatase, I'm still thinking about liver, somatostatin receptors, 5-HIA, chromogranin. So all the patient's characteristics, everything, all the treatment favored Lutathera compared to the high-dose octreotide. The objective response rate in the NETTER-1, the published in the NETTER-1 trial, was 18% versus 3%. If you look at the package insert after the drug was approved, you will see differences in the numbers. I think now it's 13% versus 3%. After the FDA approved this, for whatever reason, I don't know how they excluded a few patients, but basically, for me, it doesn't really matter. As long as you have improvement in progression-free survival, whether the response rate is 18% or 13%, that the improvement in PFS was the most important aspect of this, and with a significant p-value. Most patients had, only few patients had progressive disease that received Lutathera. As far as overall survival, the interim analysis showed that there is probably an indication of an improvement in overall survival, but we don't have the final data. I think it's after 158 deaths or 5-year follow-up where they will be able to analyze the final data with the overall survival. But with the interim analysis, you can see that we probably will see an improvement in overall survival also. So again, the response rate for me doesn't make any difference if we do have this clear-cut improvement in the overall survival in the patients who receive the Lutathera. As far as adverse events, obviously the patients who received the Lutathera had higher percentages of symptoms, mostly GI related, but the grade 3 to 4, they weren't really significant. They were still higher, but not more than the octreotide LAR. And most of these symptoms were actually related to the amino acid infusion. And I'll talk about this later. When we give this drug, we have to give an infusion of amino acid continuously before we start, during the treatment, and after for renal protection, because the drug is excreted mainly by the kidneys. So we have to give an amino acid to protect the kidneys, get the drug to circulate more in the body, and have less excretion and protection. So the amino acid that was approved for the trial was commercially available amino acid. That's what the FDA required. And it has, you only need the arginine lysine amino acids to have the renal protection. But the commercial available amino acid has significantly higher number of amino acids. So when you inject that, patients had much more GI symptoms. Other types of adverse events, which I see very commonly, mostly lymphopenia, but it doesn't really have much clinical significance. Liver toxicity, there were increase in the liver enzymes, but it's less than 1% risk of liver failure. Renal function, very important. So the patients who were on this study did not really had renal function stable after receiving the treatment. So with whatever we gave with the amino acid, we were really able to protect the kidneys, and the patient did not have any issues. So in summary, this was the first prospective study done on patients with progressive metastatic midgut neuroendocrine tumors. The progression-free survival was significantly improved with the lutetium dotatate. Overall response rate in the published NETR1 study was 18% versus 3%, and we're still waiting for the overall survival, but we can, in the interim analysis, there's suggestion that there is improvement in overall survival as well. The benefits were across all prognostic subgroups, and Lutathera had a favorable safety profile. And it's very important because these patients do not have really so many drugs to be treated with, and that's why the FDA pretty much approved this within relatively short period of time. I'm going to talk quickly about the quality of life improvements. Also, that was, it wasn't published yet, but it was presented recently. So these patients had a questionnaire, and there are multiple things that they have to answer about their quality of life, mainly diarrhea, fatigue, abdominal pain, etc. And they assess this by time to event, mainly time to deterioration, when the diarrhea got worse, pain got worse, etc. And just to show you a couple of graphs, you can see that the patients who were on the who received the Lutathera had better time to deterioration as far as physical functioning, also significantly better than the LAR arm. The diarrhea, pain, also significantly better. Fatigue, kind of not really, somewhat overlapping at the beginning, and then got better towards the end. So all these things led to the approval. The phase 3 trial, all the phase 1 and 2, mainly the Erasmus trial done in Europe, led to the approval of Lutathera in January 26, 2018. And the approval was, the indication is much broader than the study, and the NETTER-1 at least. And it's for patients who have somatostatin receptor positive gastroenteropancreatic neuroendocrine tumors, including foregut, midgut, hindgut. So it was much broader than the NETTER-1 trial. And I have a couple of slides here to just focusing on the main things that, since now this is an approved drug, what are the things that we mainly look for and where you have to tell the patients as far as mainly risk factors involved with this treatment. As far as radiation exposure, we use in nuclear medicine and radiology the ELARA principle. So based on the ELARA principle, that's how we give our recommendation for these patients. That is a sheet of paper that has all the things that they have to be taken care of when they receive the treatment. It's basically hygiene precautions for the first 2 to 3 days. For men, if they want to urinate, sit down, flush the toilet, wash your hands. I tell the patients basically just, basic hygiene precautions, because I think they'll have much more problems getting an infection if they don't wash their hands than actually from the drug itself. Minimizing contact with people for the first week, pretty much. And if there's any contamination of clothes or areas with urine, to just wipe that and then flush it separately in the toilet and washing hands. Some of the patients who are incontinent may be a problem, so you have to really maybe give more precautions for these patients, especially for the people who are helping them handling, changing their clothes, etc. So that's something to think about. Myelosuppression and also myelodysplastic syndrome, I'll talk about it later. Myelosuppression, it's something that can happen with these patients. Clinically, I've treated a good number of patients now with the trial, after the trial. It does happen, but as long as you are following their CBCs, making sure that they're okay, it's really not clinically significant. It doesn't really drop significantly like other types of radionuclides that we use. Myelodysplastic syndrome and leukemia, that's something that scares the patients, but it did happen with the patients. The median follow-up time when they found these were 24 months, 2.7% patients receiving Lutathera. In the phase 1 and 2 study, which had thousands and thousands of patients, the Erasmus, the MDS happened 1.8% and leukemia 0.5%. And that usually doesn't happen immediately. The median time to the development of MDS was 28 months and 55 months for acute leukemia. So this is something, we just have to tell the patient about the risks. Especially these patients, hopefully they live many years after the treatment. So that's something just to keep in mind. Renal toxicity is very rare. Clinically I've seen it. It doesn't happen, but you have to make sure that these patients don't have any renal dysfunction before you give the treatment. If you have an obstruction, patient has hydronephrosis, these patients are not going to do well when you give the treatment. So you have to fix that first before you give the treatment. Liver toxicity, less than 1%. Neuroendocrine hormonal crisis I forgot the interventional radiologist is not here. But when we treat these patients, for example, when we do liver-directed therapies and embolization, bland embolization chemo, they can go into this neuroendocrine hormonal crisis very quickly, within minutes from the embolization. All the tumors that we embolize just secrete the hormones very quickly in the body. So if you've seen that and you managed it, whatever happens with Lutathera is significantly less severe. But it can happen where patients can have flushing, diarrhea, bronchospasm, and it usually happens within, during the treatment and for the next 24 hours, but it decreases in frequency with time. Embryonal fetal toxicity, risk of infertility. We do recommend for the patients not to have any kids during the treatment and for 8 months afterwards, because we don't really know the effect on the offspring. We mentioned the adverse reactions already in the trial, which is pretty much the same. As far as drug interactions, this was also on the label. the patients should not be getting a short-acting somatostatin analog within 24 hours from the administration, or long-acting has to be discontinued 4 weeks before the administration. Now, clinically, let's see, patients is seen, and we're going to see if they're going to admit neuroendocrine tumors, and how we're going to assess these patients and see whether they are candidates for PRRT and how to give PRRT. So I'm not going to go through all this. This is for the medical oncologists and surgeons and pathologists. Eventually, the discussion happens in tumor board, and because I'm nuclear medicine and interventional radiologist, I do change the names here depending on where I'm giving the talk or based on what. So nuclear medicine can be sometimes here, and interventional oncology would be here. But pretty much, you really need the input of all the specialties when we're treating these patients. They can be a little bit complicated, but you have to have the input of everybody when we're determining what type of treatment we want to give. Because there are not so many treatments, unfortunately, but there are different ways of looking at this. At the beginning, you can look if the patient is surgical candidate, they're curative or supposedly curative treatments. Well, I feel that radiofrequency if you have only one lesion, but for metastatic disease, that's what we use most of the time, and we're not curing these patients. We're pretty much trying to control their disease. And if they're non-surgical, or you can't do any liver-directed therapies or radiofrequency ablation or embolization, then we have different options: chemotherapy, somatostatin analogs, and the PRRT basically is one of the treatments. The sequencing of the treatments is now still a subject of debate. This is very new, and we don't really know where we're going to sequence, for example, PRRT, whether we give it very early. Some people are advocating giving it early after they progress on somatostatin. If they have only liver disease, I believe that we still have to do liver-directed therapies with embolization, for example, ablation. But eventually, all these patients come back, unfortunately. For example, I treated patients with PRRT, and they came back a year or two later. Now we have progression of disease. We have to do liver-directed therapy, or vice versa. We did liver-directed therapy, then they progress. But if they have liver and outside of the liver, lymphadenopathy, bone disease, etc., I think this is where PRRT has a significant advantage compared to the other types of therapies, because they're not significantly effective. They are effective, but PRRT is as effective, if not much more effective, and has less side effect. So a patient, let's say, is referred for PRRT. As a nuclear medicine physician, what are the things that you have to look for? Make sure that these patients have the receptor density. If they have to have a positive OctreoScan or a net spot scan. Otherwise, these patients should not be treated. And all their lesions have to be hot. Otherwise, I had a patient where when you see all, lights up like a Christmas tree, and we start treatment, then we realize that one of the lesions is growing. You go back and you realize this lesion wasn't as hot, or wasn't even hot on the OctreoScan or the net spot scan. But sometimes you have multiple lesions. It's very hard to determine whether every single one has the receptors, but that's something to keep in mind, because that lesion that is not hot is not going to get treated. This is not Theranostics. If it has to be hot on the diagnostic scan. Making sure the kidney function is okay. Looking at some parameters, patients have to have a hemoglobin more than 8, platelets more than 75,000, ANC more than 1,000, good renal function, good liver function. I mentioned this twice. Like I mentioned, the Krennic score is only for the OctreoScan. So anything that's grade 3 or 4, it's somatostatin receptor rich tumor, which can be a good candidate for the treatment. This is an example where I mentioned at the beginning the FDG PET CT scan, but this was a very interesting case where some of the patients who have neuroendocrine tumor can have different populations, and that's something to keep in mind. We don't regularly do the FDG PET CT scan, but I'm one of the biggest proponents for that, because there's no other way of establishing how the tumors throughout the body are and how the different populations are. Even in the same liver, like this patient, had multiple hot tumors on the OctreoScan in the pancreas too. However, this tumor that is here is completely cold on OctreoScan. So this patient, you give them PRRT, this tumor is not going to respond. Plus, FDG PET CT scan gives us prognostic information. This tumor indicates that this area is very aggressive. It's poorly differentiated. PRRT is probably not going to be able to fix this. This needs more aggressive treatment, ablation, surgery, something like that. But you will not be able to tell this, even if you send the patient for biopsy. As interventional radiologists, when you look at the scan, we just use ultrasound or CT scan. I could go maybe after this, because it's easier to biopsy, and I will get a well-differentiated tumor. I will not know that this is poorly differentiated. So that's very important to know. We mentioned that the treatments is done every 8 weeks. 200 millicurie, it's a standard dose, very easy. They made it very easy for us. It doesn't make too much sense for me because of, a small patient is different than a big patient. A patient who has significant tumor burden is different than a patient who has a couple of lesions, but that's how it was approved. 200 millicurie, everybody gets it. It's very easy to write the written directive. Makes our lives easy. Concomitant amino acid infusion, that's very important. It's part of the treatment. We have to give these patients amino acids. Okay. I mentioned this before. The long-acting shouldn't be administered within 4 weeks. So this is subject of controversy also, because you can give the long-acting here, but since this distance is, this time period is 8 weeks, so you can give long-acting here, which lasts you 4 weeks, and then what do you do here? This is a big question. Some people are saying that we're still giving this dose because it's 4 weeks before the other dose. But whether we should discontinue this, continuing it, what we should definitely not do is give the dose within 4 weeks from the treatment, because that can affect the receptor uptake. And there is some data now starting to show that the tumor uptake may be even better when you have patients on long-acting somatostatin. But I think it's going to be a subject of debate. Short-acting also should not be given within 24 hours of the treatment. And then they can get their, let's say they got the Lutathera treatment, at least 4 hours later to 24 hours, they can get either the short-acting, long-acting, whatever the patients are on. This is an ideal situation of how you can treat these patients. And this is when we use the compounded amino acid. Like I mentioned before, you need only arginine, lysine to give for the amino acid. So when you have only these 2 amino acids, and they come compounded with a 1 liter of infusion, you can give it much faster. So you see the patient, they come in the morning, they get their pre-meds, antiemetics, and then they start the infusion of amino acid. Depending on what type of amino acid the institution uses, whether it's commercial or not, you have to have about 3 grams of arginine lysine. So you can make the calculation to know how much you have to give before you administer the Lutathera. And then after the amino acid is infused during the treatment, and for if it's compounded, it's only 1 liter. So if everything goes on time, it's only 4 hours later, or 3 hours after the Lutathera, you can inject the amino acid and be done with this. This is in an ideal world, and I'm trying to get to that, but it cannot. Sometimes it doesn't work as well, especially when you have so many components, nuclear medicine, the infusion center, etc. So this is what I mentioned. The lysine, arginine are the most important, the cationic charge amino acids to be infused. The volume depends whether it's compounded, We get 1 liter in our institution. We do that. If you have the commercial available, there are different kinds, but they're usually 2 liters. And because they give much more side effects, so you can imagine, you cannot really run it as fast. So instead of the 4.5 hours that I mentioned before, they can be in the infusion center for like 8 hours, 10 hours. Because some patients will not tolerate the amino acids, so you have to go very slow rate, and they spend the whole day there with nausea and vomiting, etc. And since we started using the compounded amino acid, I can tell you that from our experience, which is still limited, the patients do much, much better with the compounded amino acid. The nurses love it because it runs faster. Patients love it. And you have to give less antiemetics, so everybody wins. But because we don't know yet whether the compounded amino acids were going to get approved or not, or because they have to know that these are not FDA approved, so your pharmacy has to contract somebody to get you those amino acids. But overall, even if it doesn't get reimbursed, in my opinion, what you save in not giving the commercial one is significantly more than even if the insurance doesn't pay. This is just an example of how we use. This is now all electronic, but every patient will make sure that all their labs are within normal limits, and they get the amino acid. The amino acids are here, and this is based on for example, the Clinisol, one of the commercially available amino acids, the antiemetics, antacid. Then after. And we give them very strict parameters. And if you want these, I can give it to you after. Each type of amino acid has to go at a certain rate. And then you can give the Lutathera. And then these are PRN drugs. We had another order set made specifically for the compounded amino acid. And you can see it's only after 120 cc's of the compounded amino acid where we can give the Lutathera much, much faster. This is how the package comes in. You have to make sure that you add your lutetium on the RAM license and make sure that the dose that you're allowed to receive is adequate. Basically, for any nuclear medicine physician, we have to write the written directive. This is just basic. This is just a schema of, the rate here is, this is a slide from when we were giving. We've never given 500 cc per hour, but this is just to show you that the infusion of the amino acid and the Lutathera has to go simultaneously. We usually flush the vial after the administration, after 30 minutes. This was from the time of the NETTER-1 trial. We used the pump to inject the Lutathera with the amino acid at the same time. You have the 2 bags of 1 saline, 1 the amino acid running. The amino acid just used for the infusion. Don't forget to press the button if you're using a pump. This was the highlight of my day. And you can use alternative administrations. Also, we didn't really like this method because we found a lot of residual in the syringe afterwards. As far as precautions during the administration, make sure you get everything that may get contaminated covered. Otherwise, if the patient gets radioactive material on their clothes or your clothes, we will have to take it and leave it for 10 half-life. So if it's 6 days, it's staying there for a long period of time. So you have the amino acid infusing, and this is what we're using currently. Instead of the pump, we're using the gravity method. So we hang a saline bag, and we just adjust the rate so that we can have this infused in 30 minutes. And we measure the radiation. Usually it's about 2.3 MR per hour. So 1 needle goes to the bottom of the vial, and then the one is on the top. This one just drips the saline, and this one goes to the bottom to drain every single drop of Lutathera that's very precious coming from Italy. It's possible that it will start, it will be manufactured in the US, but for the time being, yes, that's something that I didn't know. when you start this, you have to also pay attention to the Italian holidays because they are different than the US, and sometimes you have to adjust your, when you're going to treat the patient based on if they're available to give you the dose or not. So a lot of things that need to be coordinated for the treatment. Patient comes in, labs, etc. They go to infusion center, get the antiemetic, start the infusion of the amino acid, send to nuclear medicine, get their dose. In some institutions, they're doing everything in one place. For example, if they have enough space in nuclear medicine, they can do it. But you really need the nurse to attend to the patients. So we have now one-to-one nurse with these patients because we're starting to use it, and the nurses are very afraid of anything that's radioactive. So in the future, probably their fear will lessen, and they'll probably be able to control more, to supervise more patients. And then the radiation safety officer's role is at the end to come and clean everything, especially, and it does happen. You have an incontinent patient, they go into the room where they're sitting, it's going to be hot. And then they have to do the cleaning. So you don't have to worry about that, unless you're the radiation safety officer. The radiation exposure is very low. That's why I said from a radiation perspective, it's pretty safe. But if the patient is traveling, it's probably a good idea to give them a paper because I've had patients who were, for example, treated even when they were going to Europe to get treated. When you're traveling outside of the US, it may not be a big problem, but when you're coming back, so we don't care sending radiation to the outside. But if you're coming back to the US and you're radioactive, that's when the detectors kick in. So giving the patients a letter mentioning that they received the dose can save them at least 6 hours with a TSA agent. I was going to say something, but not politically correct. The precautions, I mentioned that. So just basic precautions. We give them, I think I-131 is much more problematic, but the precautions are pretty much similar. The patients, after they get the Lutathera, so I mentioned between 4 and 24 hours later, they get their somatostatin analog. So if you do it early in the morning, after 4.5 hours, they're still in the hospital, they can get it and leave, or they have to come back the next day. I already mentioned this. It needs some resources and a lot of coordination. I cannot tell you, even that I'm here and everybody knows I'm not in the hospital, I still get texted by the nurses about the patients that are getting treated, for example, today. It takes a lot of coordination with them, but I think after you do it a few times, it becomes very smooth. And I would really, my personal, if you have to take one take-home message is use the compounded amino acids. It makes your life, the nurse's life, and the patient's life much, much easier. As far as potential direction, so okay, we have this now approved, we're starting treated. It's not the end of the story. I mean, right now there are multiple studies that are being done on PRRT in general, even for neuroendocrine tumor, combining it with everolimus, for example, a study from Germany, the COMPETE trial, comparison with everolimus. Intraarterial PRRT, I was asked about this. In Germany, they have done this. You can have higher uptake in the tumor when the patients are treated intraarterially, combining PRRT with other types of treatments, with Y90, chemoembolization, ablation, chemotherapy, and all sorts of treatments. People are looking more at, instead of the somatostatin receptor agonist, looking at the antagonist and whether that's better or not. Usually these are not incorporated into the cell, so that still is a question mark. Using other types of radionuclides, for example, the alpha particle. And Amol showed some images of patients who were treated. There are patients who were treated in Germany after they stopped responding to, they received Y90 PRRT, lutetium PRRT, and they still progressed and they received alpha PRRT, and they had a response. Of course, these are very limited. This was a study about 6 patients. Very limited data, but that's something that may be happening in the future. The alpha are right now there's a lot of interest in alpha particles. The problem with alpha particles is they're not really readily available. If we have to use, I mean, we do actinium-225, we're developing an agent for melanoma, for example, but every time we want to do an experiment, we have to see if Memorial is doing another experiment with it and wait another month to get the dose. I think those are things that will be fixed because Brookhaven National Laboratory and all those, Oak Ridge, et cetera, they know the need and they're focusing on increasing the production for these treatments, for these particles. And new indications. So what we mentioned, for example, today is mostly focused on gastroenteropancreatic neuroendocrine tumors, but there's a lot of retrospective data and data from Europe using PRRT also for non-GI neuroendocrine tumors with some success. I think for those patients, the combination of imaging, whether you use OctreoScan or NetSpot, and FDG PET scan is going to be very helpful in trying to determine which are the patients who will be benefiting from these outside of the GI or the GEP-NETs, because they can be a little bit more aggressive than the GEP-NETs. So you have to know whether these patients are going to benefit from PRRT or not. And to conclude, I just would like to acknowledge and thank all the team that works at Moffitt for PRRT, Dr. Jonathan Strasberg, who is a medical oncologist who sees 99% of the neuroendocrine tumor patients. Bob Sanders is the radiation oncologist, radiation safety officer, who was together we treated all the patients that were on the NETTER-1 trial. He has a lot of experience and very, very friendly, very helpful for other institutions that need some information on how to do all the setups. He gets calls from so many institutions and can help with guidance as far as radiation safety and also like for approval with the state, etc. Nurses, I work with my nurse practitioner, Jonna Smith, a nuclear medicine technologist, coordinator, CRU nurses, infusion center. Also AAA, who provided a couple of my slides for the NetSpot and the Lutathera, and my friend Andrea Garo, who gave me one of the head-to-head comparison between OctreoScan and the NetSpot. And most importantly, thanks for Amol for inviting me to come here and have the pleasure to go over this this subject with you today. Thank you. And I just put my email here if you have any questions for later, or you can email me. We do not do post-treatment scan. They were at the beginning for part of the study there was a safety and dosimetry part of the trial where they were getting scans immediately after, but we don't normally do it anymore. I mean, it was part of the dosimetry, and in my opinion, if you have a scan that shows you where the drug is going, you're using the same drug with the treatment, you know where it's going to go. I mean, all the studies have shown this, so doing another scan for the patient, in my opinion, doesn't really add too much. At least now that we have that part of the, at least in the dosimetry taken care of. And there was a recent meeting where there was a lot of controversy about dosimetry even. Like I mentioned, the 200 millicurie, et cetera. In Europe, dosimetry is a requirement, but is being downplayed by people from Rotterdam who treated thousands and thousands of these patients.
Regarding the long-acting somatostatin analogs, sandostatin LAR is given every 4 weeks, but lanreotide can be given every 6 or 8 weeks, indicating it has a longer duration of action. So is 4 weeks enough for that drug?
It's a complicated subject, and I always go with Dr. Strasberg over this because, like I mentioned, we cannot give the Lutathera within the half-life of the somatostatin analog long-acting. So it cannot be done within 4 weeks. So it's up to the clinician. Sometimes they may have to switch it to another one that is shorter, where they can control it better. Some patients will switch from the long-acting to short-acting. And some patients, to be honest, when the decision is sometimes not giving them the somatostatin analog at all. If they're not really having a huge benefit, then some of the patients getting Lutathera, they are stopping the somatostatin analog. So every patient is different, but at least for now, we don't know. Maybe it is better to give it while they're on the long-acting somatostatin analogs, because there's some data showing the uptake of the tumor is higher, but we don't really know the side effect, whether it's higher in the tumor, but higher also in the kidneys and bone marrow and may cause more problems. We don't know that yet. But it's going to be a subject of debate, I think.
Any other questions?
Yeah, I'm just kind of curious, how did they arrive at lutetium as opposed to Y90? Given the shorter half-life, the radiation safety would be a lot. I mean, you get through 10 half-lives of Y90 before you even get through 4 half-lives of lutetium. So.
Right. So there's always there's a balance. So it has a shorter half-life, but it has a higher energy and it travels further. Whether the other one has a longer half-life, but travels less. And it's incorporated into the cell, so you don't really need a huge distance to reach the DNA and cause the DNA breaks. So you can potentially get the same effect and without an added toxicity with the lutetium. So they are not, with the half-life is not the whole thing, because you also have to look at the energy and how you combine both of them. And there are certain cases, for example, in Europe, where you have very large, bulky tumors. They may use both. So they use the Y90 to have a bigger coverage, and they use the lutetium. So you can use them both at the same time. We don't use it in the US, but that may become something in the future where you do a combination of lutetium, Y90.
One of the slides I showed that in Theranostics, they first decrease the tumor size with Y90 PRRT and then maintain with lutetium. And my gut feeling is the bulky tumors may respond better, but these don't have that much bulky disease. This pathology does not have that much bulky disease to begin with. And so I think the toxicity is higher with yttrium-90, especially the kidney toxicity was found to be higher with yttrium-90. So to help with the toxicity, they switched to lutetium for most patients.
So then a follow-up question, totally different, probably remedial physiology for me, but why is the infusion of the amino acids protective?
It prevents the reabsorption of the radionuclide with the proximal tubules. It's kind of, it's more a charge related. So it just, instead of getting reabsorbed, it's repulsed and it continues circulating to have more of the radio tracer attaching to more receptors. Because if you inject it without the amino acid, a very high dose is going to be excreted in the urine from the first pass. So it's still, with the amino acid, it is still excreted by the kidneys, but it limits the radiation from coming all at one time instead of gradually. Plus, it helps with the biodistribution. But as far as toxicity, instead of having a high dose of going straight into the kidney, you have it to a lesser degree. And talking about the activity and the half-life, for example, alpha particles have very high energy, but they don't travel too far. So you get it very close to where you want, and you will get even a better response, regardless of the half-life. And that's, I think, what is happening with the lutetium. It's incorporated, taken into very close to the DNA. If you can have a close to the DNA, your DNA breaks are much higher to happen when you're close. So you don't really need it to travel too far.
That's what we see with Xofigo. Some of our patients who had Xofigo alpha particle therapy, I mean, we do bone scans. Jane told me that we hardly see any uptake in those treated lesions, and for years. The patient may progress elsewhere, but the treated lesions are money.
What's the cost?
What's the cost? I don't know. I think they're giving it for free. It's so good that they felt like, you know what, we're just going to give it. No, you know that I don't really know exactly. It's probably not going to be cheap. I have to say that. All radioactive material are usually expensive, especially when they're first approved, because it is what it is. But I don't like to go into the
Just as
the
a
monetary
ballpark figure, I think for all, if the patient gets all the therapies, all 6 cycles, it's over 100,000.
But and you have to also realize that the drug, how much the drug costs is one thing, and how much the patient gets charged is another thing. So I cannot really throw a price, because every institution is going to bill probably differently. And then you have the amino acid, the time chair, and the infusion center, etc. So it's very expensive, but yes, it will be more in the hundreds.
Yes, Dr. Rama.
Okay, so if the patient is getting this treatment in an infusion center, are there any radiation safety precautions to other patients?
No, actually, in the patients were using pretty much the same bathrooms, as long as they follow the precautions. They have their separate room, but other than that, there's nothing really special.
You have to cover the blue bags.
Yeah, because like I said, we had a patient who was incontinent. It makes the life of the radiation safety officer much easier if they peed and you can collect it instead of going on the floor and then they have to wipe it.
So the infusion room would have to be prepared prior.
The bathroom needs to be prepared more than the infusion room.
Yeah, the bathroom also, exactly.
So you need a dedicated bathroom.
But this is done as an outpatient, so you don't have to admit the patient for the treatment.
Any other questions? Dr. P, any questions from your remote audience?
Let me do actually, do you have any question for Dr. El-Haddad?
No question.
Thank you very much. No question, Dr. P.
Thank you. So that concludes our grand rounds on Theranostics. I would like to present Dr. El-Haddad the certificate for spending time with us and educating us on this. Thank you.